Okay, we're going to kick off. So welcome all to the Skoll World Forum ecosystem event, AdaraNewborn, halving newborn deaths in low resource settings. My name is Leith Greenslade, and for the next 60 minutes, I am your moderator as we talk about how to solve one of the biggest challenges in global health, preventing newborn deaths and stillbirths. You'll hear from a team that has a proven track record in keeping babies alive, including some of the smallest and sickest in rural Uganda. They have honed their model for over 20 years, and more than 90% of babies survive and are sent home with support. This model, called AdaraNewborn, has the power to halve newborn deaths and stillbirths in low resource hospitals, and it's poised for scaling. The team has an ambitious plan to do just that, which they will discuss today. Before we kick off, this conversation is being recorded, and we invite our audience to post questions in the chat throughout. We'll weave as many of these into the conversation as we can, and if we can't, Adara will be in touch with you via email to give you an answer. We invite now our speakers to turn their videos on. Today, we have one of the world's leading experts in newborn survival and one of its most powerful advocates, Dr. Peter Waiswa, an associate professor at the School of Public Health at Makerere University College of Health Sciences in Uganda, and the architect of many of the policies and targets driving the global newborn agenda. He's an advisor to the World Health Organization, UNICEF, the Bill and Melinda Gates Foundation, the International Pediatric Association, and many more. And he's a member of the Adara board. Welcome, Peter. We were going to be joined today by Adara's Ugandan director, wonderful, wonderful gentleman, Daniel Kabugo. Unfortunately, Daniel is ill. We wish him a speedy recovery. And he is being replaced by Beatrice Neon Shaba. And Beatrice leads all of Adara's Uganda work on research, monitoring, and evaluation. Welcome, Beatrice. And to close out our panel, Brooke Magnuson, who's Adara's Global Health Director. Okay, let's go. Dr. Waiswa, let's begin with you. Every day, as you well know, there are 12,000 newborn deaths and stillbirths globally. This is a tragedy for the families involved, and the greatest injustice for the babies whose lives are cut short before they even begin. Most of these deaths are preventable. In fact, this is the largest burden of preventable death amongst any population, a massive loss of human potential for the world. Uganda alone is suffering about 200 newborn deaths and stillbirths every day. And that number hasn't changed much in the last 20 years, but it's not because you haven't been trying. So my first question to you is, what does Uganda need to do differently in the next decade to make real and lasting progress reducing newborn deaths?
Thank you so much, Liz, for inviting me to be a panelist and for the audience to listen to me. And one of the key things is that we've reduced child mortality a lot in Uganda for children under 5. But we've not made progress for children who are newborns. And one would ask the question, why have we reduced all the children deaths, but not that of newborns? And the answer is we are good at doing the simple things. We have reduced the mortality of children under 5 because they require so little to be saved. A mosquito net would make a difference. A vaccine would make a difference. Giving drugs to prevent diarrhea or to treat diarrhea would make a difference for children who are older. But we don't have a vaccine to save newborn deaths. To save newborn deaths, we have to have a change in approach. And this approach, we need to focus on clinical care. So we usually say that for a newborn to be saved, many times you have 1 minute. If a child is not breathing, you need to intervene within a minute. Otherwise, that newborn will be dead, or the brain will actually be injured. So the challenges for older kids are different for challenges for newborns. So there are several things that we need to focus on. Having a system that works, a clinical system that works, which Adara in the Chuoko has actually perfected. In this system, we should have a focus on investing in human resources. So we need to move from simple community workers. I mean, they are important, but we shall need nurses and midwives. But on top of nurses and midwives, we shall also need neonatologists and also neonatal nurses. We shall also need to invest in emergency obstetric and newborn care, and also systems of transportation. But most importantly, there must be leadership at the center. National leadership, the government of Uganda, the Minister of Health must commit and lead the campaign. And then it can be joined by other people investing in making a difference. And we must all become accountable in order to save newborn lives. And maybe one last thing, clinical care alone may not actually be enough. We must also invest in prevention, which is mainly around the empowering women. Uganda is one of the countries with the highest adolescent pregnancy rates. I think that kind of thing is not good for newborn survival. And finally, even when we save newborns, we should know that a lot of them are going to be preterms and they may need long-term care. So we should be prepared to invest more, to work more clinically, and to focus on families. Thank you.
Can we just stay with you for a little bit longer, Dr. Waiswa? So you talked about the full range of care from modern contraception right through to the critical care of babies after they're born. Do you feel that this area of policy has the focus it needs at the health ministry? In the health ministry in Uganda, as in many countries, there are so many issues to deal with. Do you feel that newborn survival and all those areas from modern contraceptive through to good NICU care, do you feel it has the priority at the political level that it needs to have for the next decade? And if not, what can everybody do to increase the focus at the political level on this population of babies and their moms?
So I must say for about the last decade, newborn has been on the agenda in terms of especially political engagement, policy, and stuff like that, and doing pilots. But the main challenge is actually going beyond those pilots, going into implementation at scale. This is going to be a test of implementation. Can the Minister of Health and his partners work differently, invest, but also be able to manage the process? Because we have had resources like from the Global Financing Facility and from the government. But these resources, many times we've even failed to use them or to use them correctly. So beyond resources, the system of delivery of services has to be improved, and there must be commitment. And I think COVID-19 has taught us a big lesson, that health is actually at the core of development. And therefore, I hope now that COVID is going down a little bit, we don't forget, but should remind us that we need to be investing in clinical care, in healthcare, so that we are accountable for. So for me, it is there's commitment, but this commitment must go beyond the policies and also discussions in Kampala to implementation in small health centers, in hospitals, and in households, in communities.
My last question to you before we move on. There's a very thriving debate at the moment, a controversial debate in public health about decolonizing global health and making sure that the international support that's provided in any area of health truly supports national institutions and leaves a deeper legacy of investment in local leadership and teams. So the area of newborn survival and support has been one of the areas criticised in the past for parachuting in with very expensive programs, externally funded. They may last 3 or 4 years and then disappear. And you've spoken critically about that model in the past, that to the extent we have donors who want to support these efforts, they need to do so differently. Can you give us your thoughts on what would your advice be to international donors seeking to support efforts like AdaraNewborn in Uganda? How should they be doing it better so these things don't just come and go?
Yeah, I think this is a very important point, because one of the challenges the governments are not managing is because there's just too much fragmentation. We have become countries of small projects. And for me, this is one of the major challenges. So donors, if you want to make a difference in newborn health, let's learn a bit from programs that have been successful. And I think programs that have been successful, let's talk about the HIV, TB, malaria program. They have coalesced together and come up with a system for managing. About 10, 15 years ago, there were so many everybody would import medicines for HIV because they had different donors. But these donors were able to come together and say these communities should be in a pool, and then we support implementation. That reduced the amount of fragmentation. Because how do you manage like 100 entities that are implemented? That is a problem. So this is one important thing that we must learn to reduce fragmentation. The immunization program with Gavi has also been a success. So the investment is needed, and we need to work together. The work needs to be led by people in the countries. It is not that we don't have capacity. You have invested a lot over the years, and there's a lot of capacity. And many people are getting frustrated because they are not supported enough to work in a clinical setting that is convenient. So many of them are living in the system to go and work abroad or in the private sector. We must support the government system so that it is able to implement. And I think there's no alternative to that. Otherwise, we shall end up with these short-term successful projects that are not sustainable and therefore do not save lives.
Thank you. Okay, we'll come back to Dr. Weiswa later for more comments. And if you have questions, just be sure to put them in the chat because we will be answering those throughout the conversation. But let's move now to Beatrice Niyonshaba. Beatrice leads all of Adara Uganda's research, monitoring and evaluation, a critical part of the activity in Uganda. So let's talk a little bit about Chiwoko Hospital, Beatrice, which is Adara's flagship hospital, where all this pioneering work was done in central Uganda. This is where the AdaraNewborn model was developed and now cares for about 1,200 of the tiniest babies every year, ensuring that most survive. And the government of Uganda has recognized Chiwoko, the NICU there, as a center of excellence in newborn care. So tell us, why does this model work so well? And you're on mute, Beatrice.
Yes. Thank you, Leif, and good evening to our viewers and those that are listening in. There are reasons why we have become successful in our AdaraNewborn model. About 5 reasons. I'll start with the first being the partnership that we have had with Chiwoko Hospital since 1999. In those days, there were very few neonatal intensive care units, but we have come a long way with our work together with Chiwoko Hospital, working together, partnering together, and we have developed trust and confidence in them for over a long period of time. So with that kind of steady partnership, we have been able to consistently have a survival rate of the newborns at about 88%. The reason why we got there is because our approach has been a comprehensive one that looks at a mother in several stages. Most importantly, we look at a mother at 5 points of care. We look at a mother who has come in that is pregnant, and during pregnancy, along that time frame when she's pregnant, we give her the care in the antenatal clinic. We make sure she goes through that pregnancy period with great care and support at the hospital. We take her on through the delivery process, and she gives birth to her baby. We also take her through to the care of the infant, which we would call the postnatal care, and then right up to, if the baby is a preterm, she goes for the neonatal intensive care services, and for the high-risk babies, we ensure that we attach them to a VHT for follow-up while at home. So that kind of comprehensive approach has helped us to deliver success throughout this phase. On top of the comprehensive approach that looks at those 5 arms of care, we have also looked at developing and implementing a targeted training package where we train our nurses. We developed this curriculum and we use it to focus on the contributors of maternal and neonatal mortality. So we look at those points, where is the problem and what has caused it, and we package a training. We make sure there's a training package that we sell or train to our midwives, our nurses, our healthcare workers, and we train them. After developing this package with a team of specialists, we train our health workers at the local level at the facility in Chiwoko. We empower them and we continuously mentor them. So we don't leave them there after training, but we make sure that they are trained all along and we keep addressing issues together. And we generally start with the basics and move on their own. Secondly, we also equip, we equip the hospital, especially the neonatal intensive care unit. We have supported with equipment to strengthen the medicines and the supply chain. But not only that, we ensure that these equipments are maintained well and serviced through our biomedical engineering team. So most importantly, that is how we have been able to achieve success. And that is how we have come to be nominated and selected as the Center of Excellence in Newborn Care. Thank you, Liz.
I have a follow-up question for you. So I want people to understand that when you develop this level of quality of care in a NICU, word gets out. And mums and healthcare providers know that the quality of care at Chiwoko is excellent. And then admissions surge. So as I understand it, over the last decade, you've had a lot more admissions, not just babies born in Chiwoko, but often babies born outside that are very sick that are then brought to Chiwoko. And despite that surge in admissions, you've still been able to maintain these very high survival rates. Can you talk a little bit over the decade how the hospital has been able to absorb such an increase in admissions, but still maintain these extraordinary survival rates?
Yes, thank you, Laith. That is very true. Our track record of increasing and sustaining maternal and newborn survival at Chiwoko Hospital is very strong. By 2019, babies that were born weighing 2.5 kilograms had an 88% survival rate in Chiwoko. And despite all these periods of COVID and the many challenges that we've been facing since 1999, the civil unrest, the HIV/AIDS crisis, Ebola, and other hemorrhagic fevers, and now the COVID-19, we have been able to consistently give quality care, tracking, and our survival rates have been maintained at 88%. So when mothers come in, they are pretty sure that work will be done, quality healthcare will be given, and they will get their babies survive and thrive. So we have developed confidence over a long period of time, and they trust in us to deliver and to give proper healthcare to their babies.
It's the trust. The trust is key. My last question for you before we move to Brooke is, now Chiwoko Hospital is a not-for-profit hospital. It's not part of the government system of hospitals. And as Dr. Weiss was said, it's super important that this work, these models are adopted by government. And recently you expanded the model to Nakaseki Hospital, which is close by to Chiwoko, but a government hospital. In 2018, I think you began to work with Nakaseki. Can you tell us a little bit about the experience of moving the model from a not-for-profit hospital to a government hospital and what you've been able to achieve there at Nakaseki?
Okay, thank you, Leif. We moved to Nakaseki Hospital. One of the reasons that took us there was because of the increasing referrals that were coming in from Nakaseki Hospital. So that was the cause and basis of looking at Nakaseki Hospital and targeting our program there. In the interest of doing that, we thought like if we address these babies coming in with these mothers coming in with very sick babies, we shall be able to reduce the referrals and reduce the surge at Chiwoko Hospital. So when we went there, we established a 5-bed unit where we trained nurses and we equipped them, and the normal care started. The general basic care started, because we wanted to train them, make sure that they have the knowledge and the wisdom, and then continue progressively. You will realize that care in newborns is something that cuts across many departments. It's not only in the neonatal intensive care unit, but it bases its history or its foundation right from maternity. So you need support from the maternity department, from antenatal, so that this mother gets quality care and the baby survives. So after establishing the 5-bed special care baby unit, we trained the nurses, we mentored them, we continuously went there to monitor activities, we did quality of care assessment sessions with them, and we kept on improving and learning with them together with the hospital administration team. All was in the interest of reducing referrals and establishing a unit at the government hospital where these babies can receive the same care and survive with very little funds or very little resources. Now, recently, after a period of 4 years of being in service, we upgraded our special care baby unit to a secondary level neonatal intensive care unit, which was officially launched by the Permanent Secretary, Ministry of Health, Dr. Diana Atwine. She came and officially graced at the occasion, and she was very happy at what Adara was doing. And she actually sent us a letter appreciating the services that were being done by Adara in Nakaseke Hospital. I don't know if I could be allowed to share the letter, but that is if you give me time. But most importantly, the ministry is recognizing our effort in a government setting, and the newborn survival rate at Nakaseke right now stands at 96%. We have given care to over 1,300 babies have been saved. So we feel like this kind of care in a government setting is helping to reduce the neonatal mortality and will help us to achieve and to contribute to the overall sustainable development goal for neonates. And we will continue to support Nakaseke Hospital with our AdaraNewborn model, and we'll continue to equip, we'll continue to train, we'll continue to support them with the equipment that we can attain or we can have, and continuously work hand in hand with them so that we see that we establish a better neonatal intensive care unit where these babies can survive and thrive and reduce on the neonatal mortality. So that has been the way we have packaged our program.
Wonderful.
Thank you, Leif.
You mentioned the letter. Thank you. You mentioned the letter from Diana Atwine, Dr. Diana Atwine, the Permanent Secretary of Uganda's Ministry of Health. I have a copy of that letter in front of me. It is a wonderful letter. Rather than have you read it, we make sure we're going to send it to everyone who is attending this webinar in the post-webinar email so they can all take a look at it. But it's very clear the government of Uganda is very grateful for the work you're doing in Nakaseke. So let's pick up some questions from the chat. Before we turn to Brooke, we have a question from our colleague Jakob Ahmed from Ethiopia. Great to see you here, Jakob. And I love this question. So there's been studies done in Eastern Ethiopia. 10% of newborn deaths, 20% of stillbirths attributable to neural tube defects. This is an issue we don't talk about enough. And he's asking about prenatal vitamin interventions, particularly to prevent spina bifida, folic acid supplementation, food fortification. Who'd like to take this? Is this an issue in Uganda? And is the government looking at folic acid and the influence of things like neural tube defects on newborn deaths and stillbirths? Who'd like to respond to that?
Well, maybe I will, Peter here. So this is an important question that actually, as we reduce deaths from infectious diseases, a lot of these conditions begin to be having quite a high impact on mortality. Unfortunately, in Uganda and in most of Africa, preconception care has not been a focus. In fact, I've done some work on preconception care around policy and programs, but so far the implementation has not happened. Supplementation of girls and women with, especially girls with folic acid, is not happening, but also other preventive measures that are needed. Also surveillance for actual neural tube defects, because without data, it is the same story of stillbirth. In fact, Liz, I want you to bring back the issue Many people, when they think about a newborn, they just think about the baby who survived the birth. But for me, I always say that for a mom, it doesn't matter whether, in fact, I have a relative today who lost a baby as a stillbirth, and they're mourning. Because for a mom, it doesn't matter whether the baby dies 1 minute before or dies a few weeks later, they have lost a baby. Yeah. And the risks to women also are the same. So we should be talking about newborns and also stillbirth in the same way, especially in Africa where there's so much stillbirth, and yet the rest of the world doesn't have. So when we look at our rates, we're even underestimating the burden. Liz, I want to say that even the figures we give of newborns, if you add stillbirth, then they are double. And most of these stillbirths are preventable. So with good data can bring the issue to the table, and it can make it visible. And so it's the same that we need for also new tube defects. We need data, we need surveillance systems that look at congenital disorders in children. In fact, one cardiologist friend of ours said, Uganda cannot actually reduce newborn death without even having good cardiology or good surveillance at birth. He said that about 1% of all children who are born, babies who are born, actually have a congenital heart disorder. But tell me, anywhere, in fact, even in Choko, I think it is not done. So as we develop newborn survival programs, we need to advance them and make them more comprehensive. And that will require more resources, more capacity. So I think that's, for me, is the answer, that we should be doing preconception care. It has benefits to women and to the population and to countries.
That's a great answer, Dr. Weiss. So we can't forget congenital birth defects, and congenital heart and neural tube are the two biggest components there, but data is key. Jakob, if you have a link to that study in Ethiopia that you can drop in the chat, we'd love to see it, or if you can send that to us separately so we can share it. Our next question is from Tariq Tai, and it's for you, Beatrice. Tariq wants to learn a little bit more about the follow-up at home, and I love this question, because the hospital to home work that Adara is doing is really, it's a beautiful program. So if you can tell us a little bit more about the follow-up at home. And then the second part of the question is, how do you keep all the medical devices working? You've got a lot of equipment in NICUs, sensitive equipment that needs constant biomedical support. So if you could talk about hospital to home, and then how you keep all the equipment working, that would be terrific. Over to you, Beatrice.
Yes, thank you, Leif, and thank you, our viewers and listeners. You wanted to know more about the follow-up at home, what is involved in the follow-up care. First of all, this was a package that we did research on, and it is evidence-based. We called it a hospital at home package, where a mother leaves the neonatal intensive care unit and goes back home. When they go back home, what happens? Before they even leave the hospital, we train them. Nurses teach them on what to do while they are at home. There's a comprehensive package of topics that they are taught while in the neonatal intensive care unit. Whether the mother is admitted for 1 week or 2 weeks or 3 months, it doesn't matter. She has to undergo all these sessions, lactation, all these different topics that will be helpful while she's at home. When she reaches home, she is attached to a VHT, a village health team member, or you can call it a community health team member. These VHTs have been selected by Adara, but they're also a system under the Ministry of Health that different villages have village health team members, where it is taken as health center ones or health center one. So a VHT is nominated from a different village or from a village where a mother hails from. They call that VHT, attach her to the mother who is being discharged from the unit. And once the mother arrives with her baby, who has been admitted maybe for 3 months in the neonatal intensive care unit, this VHT visits the mother immediately after 24 hours of arrival at home. And the VHT takes through this mother what is going to be his role, and trains the mother on what the expectations are. If you have come back home, we are going to be following you up. We're going to make sure that the baby survives, and we have to work together and collaborate together. So this VHT is already trained. They are trained VHTs. in basic health, in basic newborn health, so they exactly know what to do. And once they know, they keep on going to visit the mother every other 2 weeks. So if the baby is not doing well, the VHT reports back to the health facility or to Chiwoko that this mother's baby is not doing well, and we're going to refer her back so that you give quality health services to the mother. So most importantly, the VHT has to go and follow up this mother every after 2 weeks. And that will depend if the baby is a high-risk baby or is a baby that is progressing normally. If the baby is progressing normally, we packaged it in a way that there are 2 systems. Once the baby is discharged from the hospital and has a very critical, has been very sick or has very low birth weight or is very ill, we package that in Schedule A. And we have another schedule called Schedule B. In Schedule A, those are the very high risk infants that need specialized care. So when they go back home, a VHT follows them up every after 2 weeks and makes sure that they get quality care. And if the baby is progressing well and they're in Schedule B, the VHT visits them after 1 month to ensure that the baby is still doing well and is surviving and thriving. So most importantly, the VHT has to follow up these babies oftenly to see that the baby is surviving. And in case they are having challenges with life, they are referred back to the health facility, to the nearby health facility. And if it needs urgent specialized care, like for being admitted in a neonatal intensive care unit, they are referred straight away to Chiwoko Hospital. And the second question was talking about how are we maintaining our equipment. Yes, in a neonatal intensive care unit, there's lots of equipment that need maintenance and servicing. So we realized that we shall keep on having systems failing, machines failing to work. So we introduced a biomedical, allow me call it a garage or a workshop where all our equipment are kept in there, and we have a biomedical engineer who keeps checking on them, servicing them every day, sometimes even once a week. They go into the neonatal intensive care unit and monitor and see whether all the equipment are doing well. So we have a stationed biomedical workshop where engineers keep coming and checking on these equipment to make sure that all the equipment are in full use and are working and are functional. Yes. Thank you very much, Liz.
Thank you. They were very, very comprehensive answers. Thanks, Beatrice. I want to move now to Brooke Magnussen, who's Adara's Global Health Director. So, Brooke, we've heard a lot about the need in Uganda and the model in Chiwoko, and it's beginning to be introduced in Nakaseke. But actually, you have a big, bold plan to introduce this model in partnership with the government in 10 health facilities across Uganda. And the goal is to demonstrate that with this model, you can halve newborn deaths and stillbirths in a facility in a given period of years, let's say 5 to 7 years. Exactly what you've done in Chiwoko, you can replicate. Describe how the AdaraNewborn scale up would ideally work.
Yeah, thanks, Lee. Great to be here today. And thanks for everybody for joining us. Yes, Adara has a pretty ambitious plan to scale this model to 10 facilities in 10 years. And as Beatrice mentioned earlier, in each of these facilities, we are going to be working across 5 different arms of care. So that includes antenatal, intrapartum, inpatient care for sick and small newborns, postpartum care for mom and baby, and then that follow-up care for higher risk babies in the community. And we think by focusing on that entire continuum of care, we can really make an impact for maternal and newborn survival. I think one of the biggest focus areas of the model is on the training of staff. The training package for each arm of this program will be focused on the most important, the most impactful interventions. And we really want to make sure that the trainings align with the biggest causes of mortality and morbidity. But we also know that training alone is not sufficient. And so that's why this package also includes support tools like guidelines of care for the bedside nurse, ongoing mentorship. We know that mentorship is so critical, that you can have a one-time training, but really feeling supported afterwards by people who have deep expertise in these particular areas is very, very important. Also, the development of quality of care committees. Beatrice mentioned this. Peter's been talking about that data, the critical importance of data using that data to track progress, continuing medical education. We know this is important to ensure that skills are retained, and ideally keeping those nurses on the unit after they've been trained. We know that's also a challenge in many settings. And then also a focus on the infrastructure and the biomedical support, as one of the viewers was just asking about. And then through all of this, really an emphasis also on leadership and governance. We know that that's a critical component that runs through everything. And I think we've seen through this model at Chiwoko that when you have this holistic and this comprehensive, all these different components together, they can create something really powerful by really creating a sense of confidence and hope in clinicians and these nurses and these doctors as they start to see those lives being saved. And those hopeful nurses and those passionate staff, those are the people that actually are saving the lives every single day. So through this process, we're really creating passionate champions for maternal and newborn care and quality improvement systems that can keep driving that change forward, that progress forward. As Peter said, we don't want to have something that works for a short period of time and then ends. And a few other notes about how this will work. We'll be in 2 different regions using a hub and a spoke approach. And so in each hub, there will be a center of excellence or a regional referral hospital that sits in the center of that. And then we will strengthen the hospital and the health centers surrounding this regional referral hospital or center of excellence. And this aligns really well with the ministry's plans more generally for the health system. And we want to strengthen that whole regional system, including improving referral pathways to really make sure we're having a greater impact on neonatal mortality. Getting that care at the right time is so critical. As Beatrice has talked about with hospital to home, knowing when it's time to refer that baby, as Peter's talked about that golden minute, the right care at the right time is just a really important piece of maternal newborn child health. And then we're also going to provide a package of basic training to the highest burden health centers in the region. So these are the lower level health facilities. And then work with the VHTs, village health teams, as Beatrice was mentioning, are the community health workers. And this is really the first line of Uganda's health system. And so improving community outreach and sensitization and that demand generation. And so this model will strengthen referral pathways between that center of excellence and health facilities and really building collaboration and knowledge within those facilities. And by strengthening that collaboration within the district, we think that also advances governance and advocacy at the local level and really pushing together for increased funding and focus on maternal newborn child health, and also really strengthening localized leadership. So we think that these things together can really make a difference for mothers and babies. And that first regional hub is going to be focused and is now in the central region of Uganda, with Chiwoko Hospital serving as that referral hub and that center of excellence. And then as Nakaseki, as we've talked about, is our second site. And then we're currently making plans for the next facilities where we're planning to work later this year or early next. And then in this region, we're seeking to improve the quality of care across 3 districts. So that's Luwero, Nakaseki, and Nakasongola. And 2 out of the 3 of these districts are ranked in the bottom third of the districts nationally in the annual health sector performance report. And all of them have very high perinatal mortality rates. And then for the second hub, we will be working with the Ministry of Health to select a high burden region that really needs support where we can work. And then we're hoping to even improve care beyond these 10 facilities, but beyond these 2 hubs, we really want to influence other facilities and other districts through knowledge sharing. We believe very deeply in knowledge sharing in Adara, and we're planning to have a knowledge sharing platform where we can make tools and resources and information available to others. And a few examples of this would be training modules, engaging PowerPoints that people can download and use to really help nurses understand the how and the why behind care, scripts to go along with some of these trainings, as well as clinical guidelines of care that are really designed for that bedside nurse. We know that nurses are the heartbeat in so many of these units. And so really thinking about how can we best really use these tools to support them. And so right now we're in the process of aligning with other people and other organizations in Uganda, especially those that have focus areas that complement Adara's focus in newborn area. So working with people who have expertise in maternity and antenatal care, and really coming together to move this work forward. So there's lots of organizations that are passionate about this work, and really excited to be working with them and the Ministry of Health to really drive change and make impact.
Okay, thank you for that. And I dropped into the chat, there's a link to the actual AdaraNewborn model in more detail so you can take a look. But let's talk about the toughest part of this to get right, which is the financing. So you're doing this in partnership with the government of Uganda, as Dr. Weisler has recommended. But you're offering to, I think, source philanthropic money initially to actually get the facilities, work with the facilities to increase the survival of newborns, do all the things you said, but then hand back over to the government. So the government is going to have to continue financing beyond a certain point of time. So this is a complicated model to get right, but kudos to Adara for thinking about it ahead of time and not just doing a program and then, exiting. The government is here from the beginning and will be required to sort of continue the program after you demonstrate that you've hit those key performance targets that you're seeking. Can you talk to us a little bit about, there are several donors, I think, on this call, but can you talk to us about how you're thinking about financing and working with the government to make sure they can continue the work after a period of some 5 to 7 years?
Yeah, it's a great question. So the way that we've been looking at this is that Adara and partners is really focused on that training component, supporting the systems, and we're also really looking to the government to provide the staffing in particular and some of the infrastructure costs for the facility. So we know the Global Financing Facility is at play in this dynamic. The Ugandan Ministry of Health has recently been updating their sharpened plan. So this is the roadmap for improving maternal newborn child health. All of these components are integrated into the sharpened plan. So the hope would be, the expectation would be that as the funding comes through the Ministry of Health, through the Global Financing Facility and other mechanisms, that the government has a lot of ownership around the staffing that's taking place. And as we see the metrics being hit, those KPIs, that really drives emphasis, that drives a belief that this is possible. It kind of creates a really positive direction for ensuring that the more focus, the more funding that we put into maternal newborn child health, we're going to see that change take place. And so as we are supporting those systems, the government can also be supporting by adding additional staff members, supporting the infrastructure, and together those two things together, I think, can really drive this forward. Right now, we are looking for anchor investors that share our commitment to saving maternal and newborn lives, and really helping us launch this model across Uganda and reach 500,000 mothers and babies. Over the next 3 years, we're seeking about $7.6 million US to strengthen this model in our first 2 sites and also launch in 4 new facilities. And so if anybody on this call is interested, or if this aligns with the work, we're really interested to chat with other people and really bring together all these people who are passionate to move this forward.
Terrific, thanks, Brooke. And I understand the way the Adara model works, 100% of donation go directly to project costs. You cover all the administrative with other sources of funding. So that's very attractive for many donors. Okay, now we've got another question in the chat. Maybe Beatrice, I'll ask you to respond to that in the chat. Tariq is asking if your VHTs are paid. I would hope so. Community health workers, frontline health workers should be paid. But if you could answer that, and there's a question about integration of other healthcare services. What else do they do? What else do the VHTs do? If you could do that in the chat, that would be helpful. And thank you, Jakob. We note your comments there. Great, we'll pick those up. Okay, what we want to do now is just get a round of closing comments from our speakers. Please, if you've got more questions, you can drop them in the chat as well. We're going to come back to Dr. Weisler. Dr. Weisler, this is the Skoll World Forum. And the theme they have is Face Forward. And they describe that as advancing the global solutions needed to bring people and planet into a thriving new era. So very optimistic words from Skoll. But I wanted to ask you, because this is something you've dedicated your whole life to newborn survival and stillbirth reduction, and to the families, to the mums and the dads and the extended families that endure this tragedy. You're trying to end that suffering, really. What does a new era for newborn survival look like to you in your wildest dreams? What does success look like?
Well, for me, success is where the government and partners are working together collaboratively to ensure that they deliver the best care that is possible for mothers and their newborns, and that these newborns actually survive. They also thrive. They become children, they become young adolescents, and very productive adults. So these days, the WHO speaks about child health redesign, which is basically looking at a child before birth until it's 19, the whole transformation agenda. So this is what we need, but it has to be led by government and donors and partners coming to enable government. I think that is what it looks like. Then too, we think that, of course, by focusing on newborn survival, you're actually looking into the future of a developed, let's say, Uganda, Africa, and the world. I always say that if children are the future of the world, then Africa is actually the future. And Uganda has a lot of children, but it needs to invest in it. Then this issue of really prevention is going to be important. Newborn care needs to be provided, as Brooke said, and also as Beatrice said, within a continuum of care. So therefore, issues to do with prevention, which may not be a major focus of what we are doing in Adara, has to be done by other people. We've talked about preconception care, which requires school health, contraception, and then of course we talked about folic acid. We need excellent clinical services. These are good not just for newborns. We actually saw that when COVID struck, systems started looking for oxygen. And I know, Liz, you've been at the front line of pushing for this. So good clinical services are not just good for newborns, and they actually eventually benefit all of us in the population. So this is an area we need to be focusing on. And I like the Choko model of the hospital to home. I know that going to beyond Choko and also going to home, I participated in that program. But I think this is excellent because although we are so optimistic about babies surviving, like Beatrice said, there is going to be those high-risk babies who have suffered birth asphyxia, difficult at birth, difficult in breathing at birth, or those who are born preterm. Some of them we are seeing, actually in Eastern Uganda, we've seen that a lot of babies have, children have cerebral palsy, and some with epilepsy, but it was caused by poor perinatal care, poor care at birth. They were injured at birth. So programs, good investment in care at birth is very good. And as I said before, having data and engaging the public. I think in the health sector, especially for newborn, we focus so much on the health workers. But it is high time that this agenda becomes like that of HIV, of COVID, whereby the media, the civil society, and the public are actually on board. And my last point is we must manage success. And for me, this is so important. Success can be failure. This is a term I usually use, that success can be failure. Many times we do these pilot projects. They are so successful, then they fail badly. We have an example of the Saving Mothers Giving Life program, which saved over 40% of mothers. But right now, those districts have actually one of the highest maternal mortality rates, because management is important, but managing it beyond the project and institutionalizing it and sustaining it is important. So management sciences is also going to be important in the health sector. Thank you.
Thank you, Dr. Weissman. And just to underscore your remarks about priority, if you look at the global burden of disease and Africa deaths in order of number of deaths, neonatal deaths are the largest cause of death across Africa, more than HIV/AIDS, more than malaria. It's this burden of deaths amongst the newborns. So absolutely, if we were to align our priorities with the burden of disease, which we should be doing, newborn deaths would be Africa's #1 health priority. Okay, Beatrice, let's keep this theme of success going. So I know that in all your years of work with Chiwoko and Adara, I'm sure you've seen so many stories of success of mums and babies and families. Can you tell us just one story that really particularly touched you? Because I think if we tell the story of one mom and her baby or babies, it really hits home what we're seeking for all moms and babies and families. So if you're prepared to share one story, I think so we can all keep in mind what we're all working towards, it would leave us all inspired.
Okay. Thank you, Leith. One of the stories that keep me going, I'll share a story of a mother who came from Nakasongola district. It's in the Greater Luwero, but it is not within Nakaseke. So about 3 to 4 hours drive to Nakaseke. She's called Nakamoga Janet. She came in, her baby was at 26 weeks gestation age. The mother herself was 18 years old. And she was nursed in the neonatal intensive care for about 132 days. That's about 4 months. About 4 months. The baby was weighing 0.77, you can call it 0.8 kilograms. So a very low preterm. When she came in, she used public means. So it took her almost like 17 hours to arrive to Chiwoko Hospital, very far. And on admission, the temperature of the baby was at 32 degrees centigrade, 32, very, very low pressure. But on admission, the team took over and they started the treatment phase. During the treatment phase, the baby had respiratory distress syndrome, which necessitated CPAP and oxygen. She had feeding intolerance and failure to thrive. But she improved on human milk fortification. She improved on formula. They gave her supplements, Hemofort and Grovit, and they also gave her the pump feeds. She also had anemia of prematurity. So with this anemia of prematurity, she was transfused 10 times. And later she gained weight and she had 1.6 kilograms on discharge and went back home. Last year, we went to follow her up and she is now 1 year. She has survived and she is living. Yeah, so the treatment took almost 4 months and 4 days around there. Yeah, she was discharged on breast milk and bottle feeds. Yes, so that was the story. And she's doing well as we speak now.
Thank you, Beatrice. Just one of many, many stories. It's so important we keep those stories first and foremost in our minds and hearts. Thank you. Brooke, I want to come to you. We've got an audience here who have listened to all of these stories very closely. In terms of next steps, what would you like to see happen next? Yeah.
Yes, great question. I encourage us all to recognize that we need to take action now. As you mentioned earlier, that there's about 200 newborn deaths and stillbirths every day in Uganda. And we need to take action now to save those lives that are being lost needlessly every single day. And every day that we wait, that's those families that are experiencing that grief of losing that mother or that infant. As Peter mentioned earlier, thinking about those individual stories and what what those people are really, really going through, that grief is very deep and that's very real. And we can often become desensitized to those statistics and those figures, but each of these babies, you know, the story Beatrice just told, that's one life and that's a family, and it's really powerful in recognizing why we need to take action right now. COVID is complicated matters. The SDGs are right around the corner. We need to take action now to really make a difference. In terms of next steps, we are seeking partners and we're seeking funders who feel equally as passionate as we do about improving survival for infants and their mothers. And we're interested in in-kind support as well. We have some really generous partners, DAC Foundation and FreeO2, that help with equipment and oxygen. So we're looking for funders and in-kind partners, and also organizations with clinical expertise and passion in these areas where we can really band together and move this work forward. So if this resonates with you, we would love to continue this discussion. I'm happy to drop my email on the link. We have many members on the team who would just love to keep talking and stay connected to work together to hit these targets. Thanks.
Terrific. Thank you. Thank you, Brooke. And thank you for answering those questions in the chat. It's not too late to drop a question in. Let's just pick up Tariq's. Yes, we've been talking about Uganda today, but AdaraNewborn is not specific to Uganda. I think the goal here is many programs like this working in many of the countries where newborn deaths and stillbirths are a real challenge. So just before we turn to wrap up, and maybe I'll ask you, Dr. Weiswer, because you have a global role here. I mean, you're very focused on Uganda, but your influence is global. Many countries need to be working on newborn survival. We have the Newborn Action Plan. There's a whole movement now. Could you just give us a sense of how strong you think that movement is and what needs to happen to make it even stronger? So we're not just talking about Uganda, but many countries having active programs like AdaraNewborn.
It's unfortunately frustrating. The movement is weak. And I was there when we were writing the Newborn Action Plan and the Integrated Women's and Children's Plan. But when you look at implementation, as Brooke said, we are 8 years to the end of the SDGs, and we haven't made any much progress. So this movement is weak. We need to translate our talk and the commitment with real resources and with actual implementation on the ground. But as long as the figures remain as they are, and the COVID has actually made newborn survival worse, then the challenge is much bigger. So if we want to make a difference at the time of the highest risk and the time of the highest burden, then I think the time is now. But really, the world will need to overwork to do so. And with all the challenges in the world, I think it will take a lot of leadership from countries, from the African Union, but from also the UN, from the US and Europe, and the rest of the world, to make sure that we invest based on data, and the data tells us that the burden is at birth.
Okay, thank you, Dr. Weiswer. I see another question from Jakob. We're going to pick that up in the following email to you, Jakob, but we note your focus on localization of public health interventions across Africa. Yes, that is exactly what is needed. But let's wrap up. And I want to thank particularly Dr. Peter Weiswer, wonderful Beatrice Neon-Shaba. Beatrice, thank you for stepping in for Daniel Kabuga. We wish him well, but we are delighted we got to hear from you because you're wonderful. And Brooke Magnuson for sharing the AdaraNewborn model with us today. In the countdown to 2030, it's just 8 years left to achieve the SDGs. It's proven solutions that should be the focus. And here is one that has been tried and tested over many years in one of the most challenging environments. So if you'd like to get involved in AdaraNewborn, I'm going to ask Brooke to put Jessica Miller's email into the chat. Jessica Miller at Adara will help you continue those conversations. But success at reducing newborn deaths and stillbirths will largely depend on governments. To Dr. Weiswer's comments, it will depend on governments embracing models like AdaraNewborn and on donors co-financing those models and aligning and embracing a national government agenda. Now, the government of Uganda has embraced this model, and we're going to send you the letter from the ministry that says so, and they're ready to move forward. The government understands the need to reduce newborn deaths and stillbirths. Adara is ready to move with them. The missing piece are the donors who can make the difference. So when you have a big problem and you have a solution that works, it's been tested for over 20 years, and you have the government ready to go, we're 3/4 of the way there. We just need our partners and investors to come in and get this moving. And then once it's in Uganda and embedded there, this is the way things grow and go from country to country to country. And this is what we have to do to reduce newborn deaths and stillbirths to those very, very ambitious targets that we all signed up to when we embarked upon the Sustainable Development Goal journey. Thank you for being with us today. Thank you to Adara. You're going to receive a contact from us after this call with some of the materials we shared and the answer to those outstanding questions. Thank you very much to our guests and especially those who ask such terrific questions. We wish you a very safe and productive week. Thank you, everybody.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.